Then I'm going to continue in English because our next guest is coming from the Cleveland Clinic. It's a very big hospital and very big, well-developed with working with e-health. They also have gone to Abu Dhabi, they're going to London. It's a very interesting hospital. And we're very proud that Matt Stanton, the Executive Director Digital Health, has come over to share your knowledge and all your experience with us. We are very curious and we are very thankful you've come to the Netherlands. Matt Stanton.
Thank you very much. Okay, thank you. I just have to start by saying this is absolutely terrifying, okay? I come to Amsterdam and it's like bikes are trying to hit me everywhere, constantly in danger here, and I'm sure my healthcare insurance does not work here either, so. And then you put me on a stage and I've got like people sneak attacking me from behind and, all right, so just promise me nobody attacks me okay. All right, and also if I don't pay attention to one side, just yell and I will turn around and I'll try to give everybody respect. So I am the Executive Director for Digital Health at the Cleveland Clinic. I'd like to just share a little bit about who the Cleveland Clinic is. I want to tell you what we're doing in digital health. So I have a lot of slides that just show a lot of different things that we've been working on. And then mostly what I'd like to talk to you about is how do we engage doctors and nurses and patients to actually use these tools. There's a lot of tools that we've developed in the past 20, 30 years that people just don't even use. And they're sitting there waiting to be used, but the trick is how do you get people to actually adopt it and engage some of these tools? So that's what I'd like to talk about. So the Cleveland Clinic, about 50,000 people employed by the clinic, about 7 million patients seen each year. We have over 3,000 physicians, another couple thousand trainees there. And we're located in several different locations, which I'll show you in a second. But I did just want to highlight number 2 in the United States. For what it's worth, we rank ourselves in the United States against all these, and very soon to overtake the Mayo Clinic. Very proud of how we've done in the past several years to achieve this. So here's where we are in the world. In Cleveland, there's maybe 9 hospitals, 30 outpatient facilities, all sorts of places to be seen in Cleveland. We also have hospitals in Florida. I think about 5 hospitals down in Florida now. We have a small place in Las Vegas. We have a very large hospital in Abu Dhabi that is open and seeing patients for the past couple of years. We are working on opening Cleveland Clinic London, so it's actually being built right now. It's right across the street from Buckingham Palace. It's kind of crazy, this building. It's going to be a beautiful location. So this describes a little bit about where we're from and how it sort of gives you a sense for the scale. What I would say, most of these digital tools that I'm going to show you now, they rest upon a foundation which we're very, very lucky to have. Our medical record system is one common medical record system amongst all these locations. Every physician documents in the medical record. Everything is electronic. It's one record. If I go to Las Vegas, they have all my records, everything about it. And in fact, I have all my records as well. I have all my records on my iPhone. So I can open up my iPhone at any time, and I can share my records with anybody here. I could shoot it to you, and you'd be able to pull it up within a few seconds and see everything about me. So everything has a very solid foundation that we're built upon, which we're very, very lucky. And it's not like that, certainly, for most hospitals in the United States are not on one common medical record system. So let's talk a little bit about what we do and how we use some of these tools. So number 1, we want to make it simple for patients to see us anytime, anywhere, any place that they're located. And there's a couple of key ways that we do that. On the right-hand side, you'll see this is actually one of our physicians, Dr. Matt Feynman. He sees patients probably, I think half of his time he sees patients online, and half of his time he sees them in person. So he sees patients that, on a Friday night pull out their iPhone and just want to be seen. He'll do that. He also sees his own patients. So when he sees you, maybe you're a patient that's been seeing him for several years, and he may just offer, well, you know what, since you're traveling to Florida, I still want to see you. How about we just do this virtual visit online? And it's just like FaceTime or Skype. And we've been doing this type of visit for probably going on about 5 years right now. And I'll show you a little bit about how that's grown over time. On the left-hand side, we have certain diagnoses also that we will see patients without actually seeing them. So we have a list of certain diagnoses where we've decided that it's appropriate to diagnose and prescribe and treat with just filling out a form. And so patients will go onto their iPhone, they'll answer a series of questions, and if they answer this way, it'll say, ask them another question. Fill out the form, shoot it to us. Within a couple of hours, the doctor takes a look at it and responds, and then the prescription's waiting for you at CVS or whatever the drugstore is here. So these two approaches have been very, very successful in opening up the doors for patients to be seen from anywhere. You can see back in 2014, got started with it. In 2018, we'll probably hit 43,000 visits. 43,000 visits, you have to keep in mind, represents like maybe 1% of the visits of patients that we see each year. So it's still minuscule, but it is starting to gain a lot of traction. And the thing that I always emphasize is at the Cleveland Clinic, it's not just like 10 doctors, 15 doctors that have really gotten into this. I took a look at our data, and in the past 2 months, we had 542 different doctors that saw a patient online. And of those 542, 119 of them saw more than 10 patients online. So we have a lot of different people that are starting to adopt this technology, and because of that, this curve here is really going to start to accelerate in the next few years. I didn't put a number there for 2023 because our CEO has not determined what the number is going to be, but he's challenging us to probably do 50% to 70% of all visits to be seen virtually without people coming to our hospital system to be seen in the next 5 years. It's going to be a huge transition, at least in the United States, I think. This is really going to start to dominate the way that patients are seen. Another area, so they can see you online, but we make it so hard for our patients just to make an appointment, just to find out where they can be seen or who they should see. So we've been designing all sorts of tools just to simplify people's access to understand who should I see, where can I go, when are you available. These types of things are generally today are all done by phone. You have to call somebody who talks you through it, ask you 20 questions about, in the United States at least, most of them are about can you pay me, and it's all about your finances, which is unfortunate. So a lot of work around tools. And these are just a couple of screenshots to give you a sense of where we are today. So you can see we allow patients to self-schedule themselves now on their iPhone. They can pick a doctor, they can see available times, they can click the time, booked. They never talk to anybody. Nobody asks them a bunch of questions, just self-scheduling. In the middle there is an interesting thing we've started doing recently to manage wait lists. So say you've scheduled something for 2 weeks out, but then you've decided that that's not soon enough for you. You want to be seen sooner. You can put yourself on the wait list and say, tell me if there's a sooner appointment. And the second that an appointment opens up, your iPhone will be notified. And actually, we send it out to like 10 people just to see who answers first. They all get this notification, hey, new appointment on Tuesday. Are you interested? And the first person who hits it gets it. So it's a little bit of a race. So that's another great convenience for patients. And then showing the wait times. So there's a lot of different types of appointments where I want to be seen today. I need something urgent. And so we display to our patients, if you go to this facility, 5 minutes. If you go here, 10 minutes. If you go to that emergency room, it's going to be a half hour. And try to give them that kind of information to help them make the right choices. We also spend a lot of energy trying to integrate remote monitoring. I'm sure you're familiar with all of the devices that are hitting the market today that are making this increasingly easy to understand what's going on with our patients when they're not with us. And this is a real opportunity for us to treat chronic diseases. So much of what we treat and so much of the expense in the United States healthcare system is in just a couple of chronic diseases here. And we know so little about what's going on with our patients because 99.9% of the time, they're not with us. They're out there living their lives, and we have no idea what's going on with them, and we have no idea how their blood pressure is today. So we've integrated all sorts of devices, and it sends data straight into the electronic medical record. It files all their blood pressures, their weights, everything that they're sending us right in the electronic medical record. And then we use tools that take all of that data and make it presentable to a caregiver so that you don't have to read all the blood pressures of all 100 patients you're trying to take care of, but we're displaying it to them, population health type displays that show, of all your 100 patients that you're taking care of, this one is the one who had a high blood pressure 20 minutes ago. So maybe we should call that patient. Maybe we should reach out to them, find out what's going on with them. And this is going to be a huge transformation for our healthcare system in the next 2 to 3 years as well. We're only really just getting started with using these tools. And once again, a lot of it has to do with how do you get doctors to actually use this data, because it can be quite overwhelming when hundreds of data points and blood pressures are flying into the medical record system. And at least in the United States today, our physicians are not paid or compensated to deal with that type of information. They're really paid when they see a patient in person. So that's a big challenge for at least in the United States. Another approach that we use, trying to simplify the way that our providers see patients when they're inpatient, inside the hospital. I'd mentioned to you we have a very large network of hospitals, but we have a lot of specialists at our main campus, our academic medical center, and not as many specialists available at all of the regional locations. So we use the same approach. We have audio-visual connections that wire up all of our regional hospitals. On the left-hand side, you're seeing a stroke patient. The stroke patients come into the emergency room. We have neurologists who are at the main campus who specialize in just treating stroke, and they'll connect up. Usually within 5 to 10 minutes, they're on the screen, and they take care of the patient in the first hour of their stroke at an emergency room. Actually, we do this for Florida from our main campus in Cleveland. We take care of the Florida stroke patients. On the right-hand side is actually something we stole from Europe. So I flew over to Germany probably about 7 years ago or so, and we saw that the Germans were the first people who had who started taking care of stroke patients inside of the ambulance. Now, they were putting a stroke neurologist into the ambulance and driving to the patient's house and taking care of the patient right there on the curb. We decided not to do that. We put video conferencing. You can see that screen into the back of the ambulance, and what you can't see is the CT machine at the head of the bed there. And we drive around, and when somebody calls 911 in the United States and they suspect it's a stroke, we show up at the patient's home. We scan them in the ambulance right there, and then the neurologist comes right on the screen and takes care of the patients. And this one, the second we launched this, we dropped our time to treatment by 40 minutes, which is enormous in stroke. I mean, people are trying to shave off 1 minute in the time to treat stroke, and we shaved off 40 minutes just by using this type of technology to connect all of our systems together. So there's some major advancements. We do a lot. I mean, it's not all just stroke. We have a lot of specialists that will connect up to different hospitals and share their expertise throughout our system. Here's another thing that we do. We've been doing ICU monitoring for probably 3 years now. We do the ICU as well as we do a lot of just our regular inpatient beds as well that aren't intensive care. In this setup here, you can see we have actually a bank of probably about 15 workstations where nurses and intensivists work purely at a computer, taking care of hundreds of patients across our system. They're using all of these screens basically it's another sort of population health technique of watching all of the data flowing in, a lot of algorithms built into it that are reprioritizing every few seconds. Another patient pops to the top and says, this patient's having trouble. Single click of a button, the medical record's brought up, all the imaging is brought up, all the bedside monitors are streaming, and the video turns on. And we hijack the TV in the patient's bedroom, and the intensivist appears on the television and starts taking care of the patient within, it could be within seconds of noticing that something's going wrong. So this is, at least for us, this is very important because most of our intensive care beds don't have intensivist coverage, particularly at nighttime. And so there is just a real lack of the ability to take care of these critically ill patients throughout our system. Another one that I wanted to show you that kind of falls into the same camp of sort of being able to remotely monitor a population. This is one that we're actually very proud of. I know that the slide here doesn't really do it justice. It doesn't really tell you what we're doing, but we call this more of like a situational awareness type of tool. So one of the big problems with using digital and data in healthcare, at least in the United States, is we know a ton, but then we hide it all because it's all confidential and it's all private, and we make it very difficult to access that information. So even our caregivers, they have to click 10 times to find out what's going on with the patient, so they just don't do it. And all that information is sitting there not being used. So what we've designed is our systems that basically we just take over all the screensavers of every computer in the unit, and when the computer goes to sleep, this pops up on it instead of just nice pictures or something like that. We pop this up, it's all de-identified, and so every time you're just walking through the unit, you see one of these patients all of a sudden has turned yellow, or you see something has gone red, and then with a single click, you can log in and you can find out what just happened. Why is that patient, what's the problem? What's going on with that patient? So we use a lot of these to just create sort of just a situational awareness when you're in the hospital of what's going on, which room is having trouble, which patient is having trouble right now. Mobile applications. This is a huge one for both our patients and our caregivers. So I just put in a couple pictures here on the left-hand side. This is my own personal medical record, so I'm not sharing anything confidential here, but this is my family. My children are across the bottom there, so I can just click on my kids and I can get all the information about their records. Across the top are all of the doctors that I've ever seen, and so I can click on a doctor and I can send that doctor a message, or I can schedule an appointment with that doctor. There's nothing hugely amazing about about what we have here. It's just that the amount of information in there is just unbelievable what we can share with our patients today. And we made a decision at the Cleveland Clinic probably almost 10 years ago that we were going to share as much information as possible with the patients. And so we release all their test results to the patients. Even, we know that they may not always understand what the result means. And sometimes you can see here my vitamin D is low. I'm out of bounds on vitamin D, which is very common for people in Cleveland because it's dark and rainy. We release all of this information to our patients, and yes, it generates a lot of questions back to us because they have their data and they want to know, well, why? What's the problem here? So they end up sending us messages. But it's been a huge, huge benefit, I think, for engaging the patient in their healthcare, understanding what's going on. It's their ability also to share their information with their children if they're elderly, or for me to know what's going on with my kids. With a couple clicks of the button, I can know exactly what the doctor said at their last visit, and I can go back and read it, and it's all in one spot, which is amazing for us. On the right-hand side, we do the same thing for our caregivers. So our doctors can use iPads, they can use iPhones. On the Apple Watch today, it sends them alerts when a lab value is returned and it's out of bounds, they'll get a pop-up. Or if some new message arrives in their in-basket, they can see what's going on. So all of these tools help our caregivers work sort of where they want, when they want, work with much more convenience than having to always go back to the office, sign into the computer, find out what's going on. This is something we've recently started this year. So I told you we've got all these specialists and they're all at the main campus, and we have all the primary care out there in the neighborhood taking care of patients. In primary care, the big challenge is, when do I refer this on? Maybe I should send this to a specialist. Is it the right specialist I'm sending it? Could I take care of this on my own? All of these types of things end up, in our system at least, driving the cost of healthcare way up. We see all sorts of unnecessary referrals sent in. So we use tools on the left-hand side that allow the primary care physician to ask a very quick question of a specialist. And then we set up on the specialist side, we route this to who's ever on duty for that day, and they kind of share it amongst themselves. And the questions start rolling in, and I just showed you a picture of my hand there just to show you we attach pictures for dermatology, or we can attach lab values. It's all done through the same medical record system, so everything is there within a touch of the button to be able to pull up that last CT scan and see what we're dealing with here. So you can see this is something, I told you we just started this year. We've gotten it up to, I think in the fourth quarter, probably do about 1,200 of these, but I see this one just skyrocketing because the advantage of doing this can be illustrated just in one department. And we do this probably in about 15 departments today, but in dermatology. So at least in the United States, dermatology is impossible to get an appointment. It's going to be 4 months before you can see a dermatologist. And the reason is dermatologists get a lot of inappropriate referrals, and they get lots of patients sent to them who wait 4 months just to be told, oh, that's all? All right, well, if I had known that's what you were dealing with, I could have just told your primary care physician to do this. So you see here, we tracked when we launched just this simple ability for the primary care physician to ask a question and send a photo. We tracked how many times did you then refer them on to dermatology. Before derm, and then compared to after telederm, we eliminated 2/3 of the referrals that were being made on these questions. And the effect of that is it frees up the dermatologist to see much, much more valuable patients where we really need their expertise. And the effect of this is it decreased the cost of care by over 60% as compared to before we used this type of an approach. And typically, the dermatologist today can turn these around in about 6 hours and answer the PCP's question. And the PCP loves it because they've just been able to deliver value to their patients that they never were able to do before, usually the answer to the question was, well, how about if you go downtown and see that person in a few months? And then the patient's left waiting to find out what's going to happen. So how do we get our physicians and our patients to work with these tools? They all seem amazing. It all seems like it should be so easy, but all of it is exceedingly difficult to get physicians and nurses to adopt this type of an approach. So I'm going to do sort of 3 patient stories, just to illustrate a few points. This is Dr. Gordeski. He's a cardiologist at the main campus of the Cleveland Clinic. On the screen on the left-hand side, that's Don, and Don is an actual patient of his. Don came to the Cleveland Clinic and had 3 separate cardiac procedures, surgeries. After that, it was determined, that he has chronic heart failure and he needs long-term management. Well, Don lives in Michigan, okay? I changed it to kilometers for you guys. I had it in miles. It's an 840-kilometer round trip from his home in Michigan to come see us, and this is not unusual. We see patients from all over the US, in fact, from around the world. So Don needs to be managed long-term. In the past, honestly, what we would really do is Dr. Gordeski would say, I know a guy in Michigan. I'm going to give you his name. He'll take care of you. And that was sort of that. And then we lost that patient. But now, Dr. Gordeski sees Don on a virtual visit. They see each other probably once every 2 to 3 months. And his daughter, Liza, on the right-hand side, she lives in New York City. So I think what the story was, Dr. Gordeski was seeing Don on a virtual visit, and he heard somebody talking in the background. And he asked Don, what's going on there? And he says, I got my phone out, my iPhone, and I've put it over here so that my daughter can hear you while we're talking, because she needs to help take care of me. And he said, you know what? This is simple. He said, give me Liza's email address. He punched it in, shot her a link, and within probably less than a minute, Liza's on the screen as well, and she's fully participating in her father's care. So how does this engage our providers? Number 1, Don had to drive a long way, and this happens all the time, and our doctors honestly feel guilty about this. They really do feel guilty about the fact that their patients have to get up out of bed when they don't feel well, they're sick. It's not what patients want to do. They don't want to drive and park at our main campus and walk in. They just don't enjoy this experience. So our providers are able now to offer something to their patients that really, really makes their patients happy. I mean, most of these visits honestly end up being 15 minutes, and Don had to drive who knows how many hours to go for a 15-minute checkup. 2, I would just point out that there's a very, very low tolerance for technology failing, particularly with physicians, because their time is so valuable. So we encountered a lot of this early on. A lot of patients like Don will join on some 3G signal, and it's choppy and it's failing. What we had to do is we had to employ a team of people who reach out to our patients in advance. So when we know you have a virtual visit, we're calling you in advance. We're saying, let's try this out. We're finding out that Don has very bad cellular coverage, and we're suggesting to Don, maybe he could get on his Wi-Fi. Maybe we've told patients, honest to goodness, patients said, well, I don't have anything. We've said, well, is there a McDonald's nearby? Like, they give free Wi-Fi, and it's great. And if you're okay with that, we're okay with that. And so we've honestly seen patients that will drive, 10 minutes to the McDonald's in Florida so they can connect with their cardiologists. I mean, sometimes I think we think that our patients really, really want their privacy, but other times our patients are just happy to have easy access to us. The third point here, how we engage our clinicians. They tell me that they feel like they deliver a better patient visit when they can see the patient in the home. They know what's going on in the home. They can identify, that this is not a good setup for this patient. They can see what problems they're going to have. The patients get out their pill bottles and show them everything that they're on. They can figure out what it is you're taking actually in your house. So we help them when they see that they can really deliver a better visit, that really helps them see the value in what we're doing. And then, like I pointed out, this multi-way video thing that is so simple to do is the patients love it. This is one of the biggest things that the doctors, they're so happy when they've done something for their patient and Liza tells them, oh my gosh, thank you so much for including me in this visit. And that, just makes our providers feel good about what they're doing for their patients and makes it a better experience all around. So Dr. Fernandez. Dr. Fernandez is a neurologist. He's actually the director of our neurorestoration department. And this is one of his patients, Maureen. And you can see Maureen, is doing a virtual visit as well from the comfort of her home. You can see in that bottom lower corner there, she's involved her family members to be a part of that visit as well, wherever they're living. But for Dr. Fernandez, this is why he likes it. Number one, this may be a peculiarity of the American healthcare system, but our doctors, at least in the Cleveland Clinic, they need credit for the work that they're doing. And so I told you we've opened up the medical records system on these apps, and patients send messages to the doctors all the time. And our doctors don't get any credit for that work, unfortunately. So when they're answering emails from their patients, no credit. And nobody can tell that they've done any work. But when we convert them over to this system and they see the patient for these types of interactions and talk to them, we give them credit. And so, our doctors are all on a straight salary. There's no extra money that they make, but at least it registers in the system, and we've wired it in the background so that they get credit for each of these visits that they're doing, and then their productivity looks a lot better, and that helps them at the end of the year when they're trying to stay with the Cleveland Clinic and get renewed. The next thing that we did with Dr. Fernandez as a great example is most of our doctors, when they get started with all these types of technologies, it's a very opt-in process. And what that requires is it requires the doctor to think about it every single time. I'm taking care of you, and I would like to ask you if you'd like to do this new way of seeing each other. And that's just, you'll never get anywhere when you use that approach because the doctor's not thinking about it. It's not the doctor's job to convince patients that they should try this new video visit or this new remote monitoring approach. So we look for opportunities where we can really talk to the physicians and say, what would be the right patient population where we could just flip the whole thing to an opt-out? Every single type of this patient, first and foremost, virtual visit, remote monitoring, all these technology tools, we're going to help get them set up. And then you don't even have to introduce it. You just tell your patient, this is how I see patients like you. And when you do that, all of a sudden, Dr. Fernandez, he actually has, I think he has 3 days a week now where all he does is see virtual patients. They don't come into his office at all for 3 days out of the week because he has so many patients that are getting enrolled in these types of approaches. And why does Dr. Fernandez benefit from that, and why does he like it? Because he gets to work from home now. So he doesn't have to come to the office every single day, and he gets to work from the comfort of his home wherever he wants, or he can come into the office and he can work there. But the providers really, really like the flexibility to work from home or work from wherever it is they are and take care of their patients. You know, another perfect example of that, telestroke. When we have neurologists on call for stroke, they're welcome to go anywhere that they want. So they go out to dinner with their family, and they don't miss that dinner with their family. They just take their iPad with them. And if they get a page, they just go to a private place, pull up the iPad, and take care of the patient. So these types of tools really open up flexibility for providers, and that's a huge advantage for them. My last story. This is Dr. Tarakshi. He is an interventional cardiologist, and his patient, Bill, had atrial fibrillation. So he was at an appointment, and they were monitoring his heart rate, and he had 166 beats per minute, and the nurses are all kind of whispering, like, you know, but he feels fine. He had no idea that any of this was going on. So when he met with Dr. Tarakshi said, you know what, how about if we monitor this remotely, because AFib can have very intermittent symptoms, and sometimes you catch it, and sometimes you don't catch it. And this technology you see there, Bill actually used his version was actually an iPhone version, but since then we've gone to a version that's on the watch. This allows Bill to take his readings 10 times a day if he wants. He can take it any day, anytime he wants, and all that information's coming back to us. And we use that at Bill's next visit, and in Bill's case, he lives in West Virginia, so again, it's a little bit of a drive, and he'd do a virtual visit. But now what Dr. Tarakshi has at his fingertips is he's got Bill's traces for the past month, and he can find, you know, that's where you were having AFib, so you definitely are diagnosed. So they diagnosed him in using this method, and then he ended up coming in for a treatment, for an ablation to treat it, and he went home, and they used the same approach to determine whether or not he was cured. And they didn't bring him back to the office every 30 days to see, okay, did it work, did it not work? They just monitored him using these very simple devices. Dr. Tarakshi had a virtual visit with him and said, you know what, the ablation worked. And Bill did not have to drive back to the Cleveland Clinic for that confirmation. So why does this engage the providers and the patients? It's just a better care model. We have much more data than we can gather at that 5 minutes, 10 minutes in the office. We can get as much data as we need, and we can run it through algorithms to draw our attention to the day and time where you were in AFib, and it just simplifies all of that data capture. What I would say, a couple of things that didn't point out in the story, but some of the things that helped Dr. Tarakshi adopt and helps a lot of our providers adopt these technologies is my department, we centralize all the expense for experimentation. So a huge stumbling block for our doctors and our teams is if they want to try something new, just buying an iPad, if you go through our hospital systems, would take you months just to get an iPad, or just to give the patient, look, you know, you don't have the Apple Watch that traces this thing. I'm going to give it to you, okay? We need to experiment and figure out if this works. So I cover all of those expenses for our doctors, so they don't have to, it's not a stumbling block. They don't have to wait and figure out how do you buy an iPad at the Cleveland Clinic, which is very difficult. The last one, educating the patient about their options. So this is what I do when the providers are facing this barrier where they can't constantly be trying to educate patients about a virtual visit, remote monitoring, what is all this stuff? And the patients have 100 questions. Will my insurance pay for it? Will this? So my team takes on all of the education for patients. We take that off of the doctor's shoulders, and if they just tell us that they want to do this, we'll work with the patient. The other thing we do is we advertise a lot, and I don't know if that's appropriate in the Netherlands or not, but in the United States, healthcare is a big marketing business as well. And so I build the demand side of the equation at the same time that I'm building the supply side with the physicians. I'm constantly telling patients, ask your doctor about this thing. Ask them if you can have this. And we constantly are telling them and advertising to them, ask your doctor. And so then a lot of our doctors who don't do this are getting asked by their patients saying, well, why do I have to drive? I live in Michigan. Why do I have to drive? Can't you do this virtual visit? You keep advertising it. And then the physician calls me and says, oh man, my patients want this. I'm like, oh, really? I can't imagine why. So you see, we're on the news, we're sending out email blasts, we are doing Facebook Live sessions, we are in Cleveland, the Cleveland Indians, Cleveland Browns, Cleveland Cavaliers, we're all over the sports venues, constantly telling patients, ask about this, ask if your doctor does this. So my point being, I build the supply side at the same time you're building demand side, because sometimes it's the patients demanding it. And if they don't even know that it exists, how can they demand this of us? So I put 270,000 there. That's just the latest figure I saw for the number of patients that have downloaded our app to do virtual visits, just one way of seeing us. But the only way we got there was by constant marketing and telling patients this is something they can do, this is why it benefits you. So those are the ways in which we engage patients. And I know that my talk was mostly about technology and just showing a few screenshots of things we do. But I honestly want to leave you with the impression that it's not just the technology, obviously. We really, really try our best to design things that make patients feel better cared about and try to address the things that the patients want. And in our market, patients want better access. They don't want to talk to people on the phone to make appointments. They want to know where to be taken care of. They want to know how long it's going to take to get into that appointment. And we try to solve all those sorts of problems for the patients because we know that today we do such a poor job of providing them access. If I were to come back and give this talk in a year, I would tell you probably totally different things that I'll be talking about. So I didn't even show the things that we're just designing right now around artificial intelligence and augmented reality for surgeries and machine learning to take care of all sort of the mundane tasks in the background that consume so much time. All those things we're developing at the Cleveland Clinic. And I would love to come back and tell you about it next year if you have the conference. If you invite me back, it would be wonderful to come back and tell you all about it. But I really appreciate the opportunity just to speak a little bit about what we've done over the past 4 or 5 years at the Cleveland Clinic and how we try to engage our physicians and engage our patients in adopting all these new technologies.
Thank you very much. It's an impressive story. It's time for some questions when it's allowed. Sure. The first one, is this the average US hospital, or are you really in the front row? You say we're the second in quality, but is this the average hospital working like this?
This is probably not the average hospital. I'll grant you that. No, we're a very large academic medical center with a lot of great resources that help us do these. And I think one of the major challenges in U.S. healthcare is that a lot of other healthcare providers will get left behind in this. A lot of healthcare providers don't have that great base of a common medical record system, and they don't have the resources to invest in all of these technologies. So it's going to be a big shakeup in the U.S. healthcare system.
Can you tell us something about the start? Because you say, well, 10 years ago we decided to go this way, but I can imagine it was not as easy as it is now. Still, it's not easy, of course, but now people are getting used to it and things like that. How was the start and how difficult was the start? Especially with the doctors and all the nurses.
Yeah, it's a very, very difficult start. One of the, you saw the first year we were able to do 70 visits like this. And in the United States, one of the biggest barriers, in addition to all those sort of challenges that I pointed out, is that in our healthcare system, a lot of these technologies are not paid for. And so a lot of this is not covered by insurance, which is a battle I fight every single day trying to work with the insurance companies to kind of come along. So this was a very, very difficult start. There's a lot of investment in time and energy and the people on my team that do this and all the money that we put towards this. But I think we really believe that investing for the past 5 years to build these capabilities, that's going to be crucial for us 5 years from now when we might be doing 50% of our visits this way.
And is it better paid then? Is it making because when it's not paid, it's a bit crazy to do 50% like that.
Yeah, it's definitely getting better. I would say, you know, in the United States we got a mixture of different payer systems. So the government, our largest Medicare, they are slowly coming along to pay for this. It's going to be a couple more years, I think, before the government pays. But you know, the other half of our business, the private payers and the private insurance companies, they're coming along much quicker.
I want to look around. If people have some questions, remarks, things like that, I come to you.
Thank you very much for a really inspiring talk. As far as I understood, so you developed all the components by yourself, also including the health record, or
No.
No.
No, no, no.
And the second part is, do you also sell that? So is it just for Cleveland Clinic, or is it also that you now start selling all your expertise and the system?
So probably 90% of what I showed you there, we did not develop. So we have, you know, Epic is our medical record system. Epic? Who's that from? Epic? They design a lot of these tools. Some of these other are other vendors, private vendors that we've paid that develop these type of applications. A few of them are things that we've custom developed because nobody's building that type of tool for us. So, you know, we're not really in the business of developing software, and we much prefer to buy software from other companies. In terms of do we sell our services? Yes, we do. So we sell many of those types of approaches to other hospitals in the United States where we'll be their coverage. When they need a question answered, we'll be the physicians that respond and connect virtually. Or, you know, maybe we'll cover their ICU for them with the ICU monitoring. So we do sell our services as well.
Other questions or remarks? I have one more, because in your country, for a lot of people, it's difficult to come even in the lowest part of the medical system. Is this not an enormous opportunity also, maybe not for your hospital, but overall, to reach far more people?
It is. I mean, you know, in the United States, I'm sure many of you know, such a large, spread out country, that is a huge problem with people have, you know, no ability to access healthcare and have nothing anywhere close to them. And so this is an amazing opportunity for connecting people in rural areas and connecting people that are hours away.
But who are thinking about it? Hospitals like yours, or also the government, or?
Yeah, no, I mean, both. So hospitals like ours have dreams of being, you know, a provider for everybody in the United States, and we're nowhere near that. But that's what we dream of, is that, you know, why shouldn't anybody in the United States be able to access the Cleveland Clinic? And why shouldn't we be able to provide those services to everybody if they want to see us?
Yeah.
We've got a province of Flevoland. What are the restrictions of providing healthcare in mobile way?
Yeah.
Because our Flevoland province doesn't get some care right now at the moment, since a week or two.
So, okay, so the restrictions, let's see.
It's only a 30 minutes drive to the next hospital.
In the United States, there's tons of restrictions around this type of an approach to healthcare. I mean, number one, does my insurance pay for it? That's a big restriction. Another huge restriction is in the United States, our providers are licensed usually state by state. And so if I see my patient on this side of the border, fine. But if they cross the border into Michigan, maybe not so fine. You know, so we've got a lot of licensure type of barriers that are very difficult. You know, we've got a lot of privacy and security barriers. Typically, those are addressed through technology so that our doctors don't worry about it at all. And we take care of all of the security in the background. They don't have to think about it. But there is a lot of work that goes into security and, you know, all of this, protecting all this health information. Lots of barriers. I could talk forever.
My next question is, you go to London next to Buckingham Palace. That's a quite old family, so the first 4 members you already have in that hospital. But the system in England is completely different from the United States. So will become a private hospital, or is it involved in a national health system?
So don't rely upon me for information on this because I'm not the spokesperson for London, but my understanding is that initially it's going to be private insurance and private pay, but I know that we're definitely talking to the National Health System about how we can work with them, and I hopefully over time be part of that.
Thank you. I come to you.
Did you evaluate whether the effectiveness of your care increased or decreased after implementation of these tools?
Yes, we do. I didn't show you any of the information about sort of how we monitor our quality and our improvement in processes. I only showed you a little bit about sort of the financial improvements, but we do. We're always, whenever we set up a program to monitor hypertension or something, we're monitoring, pre and post. We're monitoring, groups that don't get it versus groups that do get it in order to sort of drive improved outcomes and identify, are we actually making a difference? So we do that in just about all of these technologies. Being an academic medical center, we study all of it. They're always interested in sort of, what's the quality improvement here? So definitely. I mean, for many of these, we find, that the quality is as good, if not better. I mentioned lots of advantages to being able to see patients in their own home setting where they really live and not, when they come to the office and, maybe they're not sharing everything with you. They're not telling all the story of what's going on, and people feel much more comfortable in home, and you learn a little bit more about what's going on. So yes, study a lot.
I look around. The last question is for you.
Yes, thank you. I was wondering, how do you engage patients with the tools you design? Mm-hmm.
Well, I mean, a lot of it is straight marketing. So a lot of it is building awareness with them and all the digital marketing that I kind of spoke to. And then a lot of it is once we've kind of hooked them and they've downloaded the app or they've registered, then we're sending them different messages about this is how you can use it. Did you know it's flu season? Why come to our hospital and infect everybody? Stay at home, we'll take care of flu that way. I mean, I'm serious, we've sent out coupons in the past saying, it's flu season, type in flu and we'll give you a discounted visit, trying to keep people out of the hospital, So we use a lot of just digital marketing techniques to engage patients. But I mean, I spoke a little bit about one of the most crucial ways that we engage patients is when we know that you as a patient are about to try this new tool, we're proactively reaching out to you. And I have a team of people that are calling people and saying, oh, let me help you download that app. Because, I mean, the patient, they don't know their Apple ID password. They have no idea how to download an app. They've never done it before. And we're walking them through all these steps. So there's a lot of hand-holding to get patients to a point where they can do these types of approaches.
Once again, I'd like to thank you for coming to the Netherlands, share all your knowledge and experience, and it has been very inspiring for all those believers in mobile healthcare. So thank you very much, Matt Stanton. Thank you very much.
So